Welcome to today's free VITA webinar, a video education offering from the Vestibular Disorders Association. And today I'm just thrilled and honored to have with me Dr. Danielle Tate. She's a vestibular physical therapist specializing in the evaluation and treatment of patients with vestibular and balance dysfunction. We hope to bring you a patient-friendly information offering today to help you understand benign paroxysmal positional vertigo. More about Danielle. She completed and passed her vestibular competency course presented by Duke University School of Medicine and the American Physical Therapy Association. She developed a 3D printed educational model of the vestibular organ to aid in both patient and clinician education. And I think she coined the phrase vestibuloholic, if I'm not mistaken. So that's pretty neat. And she also has a podcast that is a vestibular-centered podcast called Talk Dizzy to Me, which you can tune in to hear anywhere you can get podcasts. And she also has a website and presented lectures on vestibular rehab and vestibular-related research. She's lectured to audiology practices and has and DPT programs regarding vestibular testing and treatment, and she's a board member of the Vestibular Disorders Association, serving on multiple committees, including the Legislative Advocacy Committee, the Medical Advocacy Committee, the Virtual Conference Committee, and the Professional Membership Committee. So if you think that's a lot of committees, that's how much help we need. So because there's so many things to do, but we love VITA. She and I both commit a lot of our spare time to do it. So in the end of this broadcast, if you're happy with what you hear, we're going to show you some ways to get in touch with VITA and go to the website and then get involved as well. We're thrilled to have you all joining us from all over the world tonight. It is a wonderful privilege to have this technology to share information with those in the vestibular community. So without further ado, I bring you Danny Tate to talk about BPPV.
Hello, everybody. Well, first, I think we should probably talk about what those letters mean, right? BPPV. Yeah. We say them so quickly sometimes, and they kind of run together. They stand for benign paroxysmal positional vertigo. So in theory, it's not going to harm you. Happens suddenly when you change positions and you have this false sensation of movement when there shouldn't be movement, or termed vertigo. So this is something that has been very, very common. It can happen out of the blue, out of nowhere, and takes a lot of people by surprise. And we really want to work on educating people to know much more about this condition, because it is so common and it's something that can be helped, and it's something that can improve quality of life when this does happen. It's very scary when it comes on, right, Kathleen?
Yeah, very scary. How common is it?
It's actually very common, especially as we get a little bit older. In our older populations, they say about 1 in 10 people have it and don't even know they have it. They have undiagnosed BPPV. The prevalence of BPPV tends to increase as we age. Although I will say it's not uncommon for us to also see it in a younger patient population as well. So, we can see it from a very young age, but we're more likely to see it as we get into an older population.
What does it look like for patients?
Well, it can actually vary from person to person. The typical textbook response to this would be every single time you change positions, the room spins for a few seconds and then stops until you change positions again. But you and I as clinicians know that this can actually vary a lot. A typical response might be someone goes to sit up out of bed in the morning and the room starts to spin, and it lasts for a little while, makes them feel nauseated and uncomfortable, and we start to panic. We go, oh my gosh, I'm having a stroke, I need to go to the hospital. And we end up going to the hospital. They run every test under the sun. They refer you back to your primary care doctor and maybe give you some medication to help with the nausea and the dizziness. And after going through a couple of channels, typically you'll end up at an ear, nose, and throat doctor's or a physical therapist's office or an audiologist that can diagnose and test and do some treatments to help you feel a little bit better. For some people, they have that violent room spinning feeling when they change positions. And I've also had people that really aren't too bothered by motion sickness that feel just maybe a little wobbly and imbalanced or disoriented for a couple of seconds when they change positions. So it's actually on a pretty big spectrum. You could go anywhere from mild symptoms to more severe symptoms.
Mm, mm. Well, how is it diagnosed?
That's a great question, and probably one of my favorite things about the job, diagnosing or evaluating patients. You can be evaluated by somebody who has a background in treating vestibular disorders, and they can put you through a series of different positions, and they can watch your eyeballs react to different positions and figure out where those crystals are and how to put them back to where they belong. To kind of back up for a minute, BPPV is this condition where we have things that are kind of knocked loose in our inner ear organ. So this isn't where you can put a Q-tip, not in your ear canal. It's not your middle ear where you've got your hearing bones, your eustachian tube, where you feel maybe clogged and get ear infections. BPPV affects the inner ear. This is inside your skull, surrounded by some of the hardest bone in your body, and it's attached to your hearing organ. On the back of that hearing organ is another little network of different sensors. So you've got these canals that have a little sensor at the end of them. And then you've got two smaller organs that are coated in these crystals, which are kind of held in place with glue or gel that hold them down. And they've got a really specific purpose. They tell us where gravity is. And these little crystals are made up of calcium carbonate, which is similar to like limestone or even the makeup of bone. So as we age and as our bones become more brittle, in theory, these little crystals may become brittle as well, and they can flake off, which is a problem because when we change positions, like lie down in bed at night to sleep, or lay our head back at the dentist's office to get some dental work done, or put our hair back in the bowl at the hairdresser's, those little crystals can sink like stones in water and enter these canals. These canals tell your brain where your head is moving in space. So if those crystals move around in those canals, they inappropriately trigger your brain to think your head is moving when it's not. And as a result, your eyeballs will kind of make an adjustment and make these automatic pattern of movements as those crystals move through the canals. And it's when we watch those eyeballs that we can diagnose where those crystals are and how to put them back into place with these really well-known and tested maneuvers that we've developed over the last many years.
It's interesting that you say you look at the eyes because it's an ear problem. So it stands to reason that the doctor would look in your ears. In fact, I've had patients who say, the doctor looked in my ears and said everything was okay. What's up with that?
It's crazy, right? So, we can look in the ears only so far. We can't see the inner ear organ. And where the inner ear organ is connected to the eyes is through the brain. So I want you to think about if you were to run around with a video camera, just kind of walk around or run around and then watch the video afterwards. It's miserable. It's like Blair Witch Project all over again.
Yes.
Everything's moving and shaking and bouncing, and it's hard to see what's going on in the scene. So if we didn't have an inner ear organ, that's what we would look at every single day. So our inner ear tells our brain where our body and our head are moving in space so that it can either excite or inhibit the little muscles around our eyeballs to stabilize them within our head as we move. Right? So this is kind of similar to watching a tennis match, being able to clearly track a ball go back and forth, be able to walk around and read street signs, or even run and be able to see things as we run without everything bouncing. So if our inner ear is not working appropriately and it's not sending the correct signals to the brain gets confused and inappropriately affects the eyeballs, which allow us to see when there's something wrong going on.
That's interesting. So it sounds like you're saying that the inner ear feels motion of the head so sensitively that it makes the eyes able to focus on things while we're moving around.
So sensitivity, yeah, oh, absolutely, and especially in different movements. So those little organs I mentioned earlier that are coated in the gel and the crystals, they sense linear motion. So they tell you if you're moving in a car.
Okay.
Yep. So like if you're moving in a car, or you stop suddenly, or even when you move up and down in an elevator, these nice gliding, sliding motions. And then those canals where those crystals can get stuck in BPPV tell you where your head is rotating in space by a movement of fluid in there. It's a really complicated little organ and can have a lot that goes wrong with it in different circumstances. And
how big is it?
Oh, it's about the size of a dime. This thing is teeny, teeny tiny, and that includes the cochlea or the hearing organ. So this thing, if you can look at your thumbnail, should be able to fit on basically the end of your thumbnail. It's that small, which is why it's hard to do any sort of imaging, right? This whole organ is encased in bone, so we can't X-ray it. It's not going to show up on MRIs. We're not going to be able to see those little crystals. We've actually hadn't seen those little crystals just until a couple of years ago when somebody was able to view them through an electron microscope. They are so small, and those little canals that they travel through are only about the size of a capillary, which is the smallest diameter of a blood flow system in your body. I mean, it's microscopic and super small.
So does it show up on MRI?
This BPPV is not something you'll be able to image and be able to see, or your doctor is going to be able to run tests on, which is really unique because that's one of the few things, right, that we have to look at function. We have to look at a reaction in the body in order to diagnose this. And this is why it's so important to have somebody that knows vestibular background to really put you through different tests. You know, there are 3 different canals in your vestibular organ. So there are canals that are more common when it comes to this condition or the posterior canal, but you can also get little crystals stuck in the other 2 canals that are in the vestibular organ, more commonly the horizontal. Each of those canals are positioned differently in the head and might require different maneuvers to scoot those particles out of the canal and put them back where they came from. Once you clear out those crystals from the little canal that they're stuck in, then those symptoms should go away because the inappropriate activity of that canal being triggered when it shouldn't be should be resolved.
Well, that's amazing. Let's get back to diagnosis. So we can't look at the ear, we can't image it, so MRI is not really necessary. Does the story tell anything for people? And then I want to dive in a little deeper to what you see in the eyes. That's so cool.
Absolutely. Well, what's interesting about vestibular dysfunction is most of the time, if you let the patient talk and tell you what they're experiencing and going through, they'll tell you exactly what you need to know. So we always start with a very comprehensive history. I want to know about your medical background, what you're feeling when the attacks happened, what you were doing when the attacks came on, how they made you feel, how long did they last. There's all of these questions that we can dig into to kind of help formulate an idea in our mind of what may or may not be going on, which is hugely helpful as we run through then some tests. So I could spend anywhere between 20 to 30 minutes alone on a history because these patients can do a really great job of describing what's going on, but sometimes it's hard because the feeling is so foreign and different that you almost feel like it's hard to put into words what's going on. So once we get through that history, we have a pretty good idea of what's going on. We do a whole lot of other things to look at the patient's balance. We look at other tests that look at the function of the brain and how they're coordinating their movements. We rule out other possible potential issues, and then we get into the fun parts. If you are lucky enough to have infrared goggles in your clinic, you can have some equipment that looks really close at those eyeballs so they don't miss anything. So you put those little goggles on, and the clinician who's putting you through some tests will be able to put you through a different series of positions or movements and watch your eyeball on the screen to accurately diagnose what's going on and how to treat it.
That's amazing. Do we have a clip of that?
We do. I was hoping you'd play it. So I brought a little clip of somebody who is sitting on a treatment table wearing those infrared goggles. And what they're about to do is, with their head turned to the right, they're going to lie down flat. And you're going to be able to see this pattern of eye movement that's generated from these little crystals moving around in a canal.
Okay, let's take a look.
1, 2, 3, lie flat. This is what.
So here you can see the patient's eyes start to rotate and beat up towards their eyebrow. Every canal in the inner ear has its own specific eye movement. So looking at this patient, I know it's the right ear that's affected and it's in the posterior canal. So just from that one test, and after going through the rest of our history, I can accurately say the patient has this pattern of eye movement, or also termed nystagmus. and for that's displaying issues with this canal. And then we could go right into a maneuver to try to get those crystals out to clear the canal and help resolve those symptoms of BPPV.
Can we look at that again? One thing to look at is which eye that is, because, and I think that's hard. You were talking about it being the right eye, and I know we're not training people to be clinicians, but just for the patients, you can kind of see which one might be the nasal side of the eye and see if you can catch this rotary component that you were talking about. That's what's interesting. It's sort of subtle, isn't it?
Very subtle, and sometimes something you have to really look closely at.
Okay, well, let's take a look again. I think we have
1, 2, 3, lie flat. This is what.
Sometimes if you look at a little blood vessel of the eye or a discrepancy in the iris, you can see the torsional component, but you can definitely see how the eye beats upwards towards the top lid. And you're looking.
Is the eye movement correlated with how bad the person feels?
So interestingly enough, not necessarily. It all depends on how the patient subjectively feels their vertigo. So I've had some patients where the eyeball might just barely twitch or move and they feel like they're flying off the face of the earth. And I've had some of my older laid back gentlemen who don't have a care in the world when it comes to motion sensitivity. When I lie them down, their eyeballs can be bouncing out of their head, and I'll ask them if they're dizzy. They're like, no, why? So the quantity or the how much the eyeball is moving doesn't necessarily correlate with how symptomatic the patient is feeling. However, I will say when you have a stronger response, typically the patient is feeling it a lot stronger.
Yeah, I would agree with that. And I think especially if they don't have goggles on and they actually see the room moving and spinning. So in those dark goggles, those are infrared. So just so people understand, the patient in that clip is seeing darkness, really, right? And so is it true that it doesn't make you as dizzy if it's dark or if your eyes are closed? But if you see the room spinning, it can really make you feel like you're on a merry-go-round.
Yeah, absolutely. If you're watching everything move around you, it's hard to orient and it makes you feel really off and disoriented. But if you are in the dark, you can't fixate on something. Your body may feel like it's moving, but at least you're not getting as disturbed by the movement in your vision. I do use that as a little bit of a diagnostic helper in my history, because I'll have a patient say, oh, I turned over and all of a sudden my alarm clock was moving up and down. So a lot of times patients can notice that they have nystagmus, but they can't quite put a name to it. And that's where we do a lot of education at the end of the visit. I
mean, who knows the word nystagmus? Just like,
we're still working on getting the term vestibular to be a household word.
True. Yeah. Well, and you know, I think I have a lot of people who say, is this the worst you've ever seen? You know, when you look at the eye movements and the amplitude, like you said, of those eye movements, does that mean that the BPPV is worse or better? Or is it just, you know, there or not there?
I typically say there or not there. I'll reserve the worse or better for patients who maybe have recurrences, where I can track how the patient has responded over time. So I might have a patient that came in and they had a really strong or high amplitude case of nystagmus with their positional testing. Maybe they come back 6 months later because they feel their symptoms come on again, but clearly they're not as symptomatic and the quality of their nystagmus or their eye movements is significantly less in comparison. We'll say, oh, we caught this early, we'll nip this in the bud and do our treatment, but I wouldn't necessarily say better or worse. I usually say positive or negative. It's either there or it's not. And sometimes there can be a gray area there too. I've had some patients where they can feel the symptoms come on sooner than I can see the result in their eye and positional testing. And sometimes it just takes some patience and getting them back in the clinic for additional testing down the road if anything changes.
Dr. Tate, there's some comments about taking medications for this and whether or not that has an impact on, you know, the evaluation or the treatment. Can you speak to meclizine, dramamine, scopolamine, those antihistamines in BPPV?
Yes. So a lot of time, meclizine will be given out to a patient when they're having acute symptoms. Typically, we see this a lot in patients that have vertigo that doesn't stop. Right? If they have a vertigo attack that's lasting hours on end, that's where meclizine is great because it's going to help reduce that feeling and reduce your nausea, get you functional again. But in the case of BPPV, I try not to recommend it unless it's affecting the patient's function on a daily basis and their safety. Meclizine is a suppressant. It is suppressing the function of the inner ear organ, so you don't feel as symptomatic. But the problem is, it's not that the organ isn't functioning well, it's functioning fine. It just has these little crystals that are making it inappropriately react when it shouldn't. So now we've got somebody who is going to be a little dizzy with changes in position, and we're giving them a vestibular suppressant that can make them a little woozy, a little drowsy and sleepy. And to me, I worry about my patients becoming a bigger fall risk. Now, once we get through evaluation, if we treat them for BPPV and we resolve everything, we want that system to keep working as much as it can. We want it to stay active and we want it to move. If we continue to suppress that inner ear and its function, then we're not going to get back to feeling normal as fast as we could without the Meclizine. I'll also say that we never want to, not never want to, but we tend to not like to evaluate patients on Meclizine because it can suppress or dull the reaction of the eye movements that we're looking for and need to see in order to diagnose and treat properly. So for a lot of vestibular testing in general, they recommend that you refrain from taking anything like Meclizine, scopolamine, dramamine, anything along those lines.
I'm going to jump in here and just remind people, because I know that there are people listening to this webinar who aren't sure what kind of vestibular problem they have. Maybe they haven't had a diagnosis. And, you know, we are recommending that you find, like you said, a professional who is well versed in the diagnosis and treatment of vestibular problems. And BPPV is one of the more treatable conditions, one of the most treatable conditions of all the kinds of vestibular problems. So it is well researched, and we will talk about the research coming up. But would you say that if a person comes in with undiagnosed vestibular problem and they had BPPV, is there reason for hope, or is it hopeless?
No, absolutely. I mean, I'm always hoping and praying that when somebody walks in through the door, it's that they just have BPPV. This is one of the most common and also most treatable conditions of vestibular dysfunction. So much so that with these canalith repositioning maneuvers, or these maneuvers to put the crystals back where they belong, they can be as effective as up to 80% effective in one visit. So when you are told by your ENT or your doctor to try vestibular therapy and go see somebody, we're not talking, you know, twice a week for 12 weeks. We're talking about a potential 1 or 2 visits to diagnose and treat and potentially continue working on the symptoms that come with BPPV. So this is something that there is a ton of hope for, that this is something that's so common that a lot of people are gaining more expertise and knowledge behind that. You can find help, and we have a great directory on VITA at vestibular.org. And you can search through our directory of healthcare professionals who are professional members of VITA that treat this commonly. And you can search by your zip code, you can search by your location in your city. It's something that I recommend, and actually I use every day. I get a lot of questions from people all over the country and all over the world from our podcast and our presence online. And I can very easily go to the directory and point them in the right direction and help them find somebody. So this is something that is very hopeful, very treatable and manageable, and is also something that might stick around in your lives for a little while longer as we see recurrences. You know, I think that we've talked about recurrences in the past, Kathleen, that this might not be a one and done. This might be something that pops up periodically over your lifetime. But the more you know about the condition and the more that you kind of build your team of people around you that can help, the easier it is to recognize it and treat it quickly to resolve those symptoms faster.
I think that's well said. And I know in my clinic, I think people put me on speed dial, and, you know, so they hope they never get it again. And the success rate is very high. I do, you know, multiple treatments in a row, and then 2 weeks after they're symptom free to make sure that things are in the right place and stay in the right place. And then I always tell them, if it comes back, call me. I'll try to get you in in the next 24 hours, because we sort of know the patient a little bit by then, and we kind of know what they don't have, and we know that they do have this. And would you agree that someone who's had BPPV is more likely to get it again than someone who's never had it? I think you've frozen, Danny. We might have to get her back. There she is. She's
Oh,
gonna
sorry about that.
That's okay. So I was just saying, you know, do you think someone who's had BPPV is more likely to get it again than someone who's never had it at all?
Definitely a lot more likely. The chance of recurrence is pretty high. And that's something that I like to make sure that we educate people on day one. When somebody comes in and this is their first time experiencing it, we make sure we really hit home education on what this is, why it happened, how we're treating it, why it works. And then also, as they go through therapy or as they go through treatments, making sure that they understand all of this and what they can do to potentially prevent other recurrences in the future. Because, I mean, I have some recommendations that I make to my patients to kind of help reduce the possibility of recurrences down the road. Would you do the same thing, Kathleen?
Yeah, for sure. I mean, and like I said, I think when you were frozen, I said that I do follow up 2 weeks after they're symptom free to try to reposition again and make sure. And I think that really decreases their chance of recurrence. So the particle repositioning you're talking about is one of the treatment options. But let's say, you know, you have this vertigo and you don't really know what to do about it. Maybe the doctor says he doesn't know what it is. You know, why see a vestibular therapist? Why are they different than the doctor? And what are the options for somebody?
There are actually a good many options. So, you know, there's the options that we had many, many, many years ago was just wait and hope and see. You know, sometimes there are chances that this will go away in a couple of weeks. And to be honest, for people who have had BPPV chronically and didn't know they've had it chronically, they'll tell you a health history of saying, oh, every once in a while, every other year or so, I get this for a couple of weeks and then it goes away. And then I'll pop up again down the road a couple of years later. So it can go away on its own. So we've got that wait and hope feel or a treatment approach. Earlier on, when they started doing exercises to help treat this, they did something called habituation exercises. And there are, I think the most common one we use today is the Brandt-Daroff exercises, where you basically go into provoking positions multiple times in a row consistently for many days in order to help the body readjust to having these particles moving around and not feel so symptomatic. And that kind of goes into the idea of self-treatment. Nowadays, with the internet and with Google and with everything out there, with all these resources, many people will hop on and they'll start to Google their symptoms and they'll be directed to a YouTube video with these candle repositioning maneuvers to try at home. There are also
what do you think about
complementary.
that? What do you think about that? Do you send people to treat themselves?
I always recommend getting diagnosed by a trained clinician first. That will always be my primary recommendation, just because I've seen how BPPV can be tricky. There are different types of BPPV, and there are different instances where just performing a maneuver from YouTube isn't going to cut it, and we don't want to complicate things. However, I also found that self-treatment can be very effective. There was a study that I found online that looked at the efficacy of these self-treatments through YouTube, and they found that patients were about 50% effective at reducing their symptoms. And I actually filmed my own video that I put on YouTube, mostly because as I was looking into this, I noticed that there were a lot of self-treatment videos that were wrong. Either wrong, gave bad advice, didn't follow clinical practice guidelines or best practices. So I actually developed some home treatment maneuver videos to put out there so I can give them to my patients after I evaluated them if they needed a lifeline at home. So self-treatment is an option. It is an option if you feel comfortable and safe. Some people are very symptomatic and can't get through a treatment without medication or help from somebody. For some people, the self-treatments aren't successful on their own. And some people just aren't safe because they're so symptomatic during their treatments. So it may be great for some, but I do recommend always to follow up with a clinician for diagnosis and treatment first, and then kind of go from there.
Yeah, I think you said something key there. It's tricky because people don't necessarily have access to trained professionals. We gave a list of, a way that you can find someone in your area. We know we have a worldwide audience at Vita, and everyone doesn't have the same access. But in the US, we do have these clinical practice guidelines. We do work on, evidence-based medical practices and research-based best practices. When I began seeing vestibular patients 30 years ago, we didn't have those. But now there really are best practices for BPPV. And am I right that it doesn't really include a wait and hope or do nothing, sort of thing? I mean, I think that the particle repositioning that you're talking about from a vestibular therapist is in fact in the clinical guidelines, right?
Yep. Oh, yeah. I think the recent practice clinical guidelines were released back in 2017. They were updated, if I'm not mistaken. And yes, the cannula repositioning maneuvers are top tier, #1. And they are also sometimes recommending that after these repositioning maneuvers, you might not feel completely back to normal, and maybe you need to do some vestibular therapy, which are very specific targeted exercises to help that vestibular system or that inner ear readjust a little faster after going through BPPV. So there's
Can you just go online and find some, or do you again need someone to help you?
Especially with the exercises, I will say with BPPV, a lot of people can get lucky and they can Google and they can try the Epley maneuver, right? The Epley maneuver is the maneuver that is most commonly used to treat the most commonly involved canal with BPPV, right? So a bunch of people get lucky. But when it comes to the exercises, everybody is different. And you don't want to just pull vestibular exercises offline and try them, because you can actually make yourself feel worse. So when it comes to vestibular exercises, this is where you definitely want to get in touch with somebody that has a vestibular background in the treatment and evaluation of what's going on, because it's very specific and you want to make sure you're doing things correctly. Just because we have similar exercises, they look similar in nature, it doesn't mean they're doing the same thing for all of our patients. So when it comes to vestibular therapy, definitely see somebody that you can follow up with telehealth online, or see somebody in your area that has some background and knowledge to address those. I wouldn't recommend just pulling vestibular exercises offline and giving them a go.
Are there risks with this particle repositioning maneuver? If a vestibular therapist says you have it and they want to treat you, what are the risks?
They're very, very low, if any. Really, when it comes down to repositioning maneuvers, unless there's something very significant in your background, in your medical background, it's almost workable for everybody. Some concerns that we have when we go through our medical history is what your neck looks like, right? We want to make sure that you have the range of motion to go through treatment, that you're not losing or have compromised blood flow or any history of potential stroke. That's going to be an issue. But even then, we have maneuvers that we can modify to put you through and make you comfortable and accommodate those things. So really, when it comes down to it, there are very few risks when it comes to doing these cannula repositioning maneuvers, if any. And if there are any risks, those are taken into consideration by your vestibular therapist who's going through your history and your evaluation. I always put my repositioning testing and maneuvers at the very end of the evaluation to rule out anything else or any other complicating factors that might affect that.
That's a good point. What are the risks of, you talked about really no risks of treatment in terms of, because you're making some medical decisions on it's appropriate for most everyone and we can accommodate most people. Are there risks for not getting treated? I mean, do you think that if you don't treat it, is it more likely to come back? Can a person hurt themselves? Does it lead to stroke or any other disease?
Oh, I mean, yes. I always have a little problem with the term benign paroxysmal positional vertigo because it's really not a benign in the fact of what it can cause if it goes untreated. So I'm thinking about my older patients who might get up in the middle of the night to use the bathroom, and they get up and they start to walk across the room and they have a sudden onset of this vertigo, which results in a fall. There was actually a study done by Johns Hopkins that found that people with untreated BPPV are actually 3 times more likely to fall because their vestibular system is just inappropriately working and not giving them the correct information. It also takes away from your brain's ability to focus on things like balance. You have a lot of brain fog, which might make it more easier to fall and catch your toe on something, miss that throw rug or the loose brick in the sidewalk. It's something that I like to make sure that we treat in order to help improve patients' quality of life, but also improve their safety. So the risks of just letting it go are typically not worth it. I always recommend going through the 2 minutes of discomfort of an Epley maneuver to resolve the issue and get it in hand before anything else happens.
You know, I think there's people watching who maybe haven't had an evaluation by a vestibular therapist and haven't been told they have BPPV either. Is it useful to see a vestibular therapist just to see in case you might have it? Because I think also in the comments I'm reading people who've had it on and off for years, and so we're telling them it recurs. But in my practice, I would encourage people to try to get it treated properly or with the particle repositioning in the hopes that really it's not something that you have to look forward to every spring with the flowers blooming, you know?
Yeah.
What's
Absolutely.
your comment on that?
Yeah, absolutely. You know what's really funny is this question has a bunch of different layers to it. I actually have a bunch of patients who I've treated, and then their friends start to trickle in because they go, "Hey, I think I might have had something like that. That sounds familiar. Could you just check me?" And those studies that I talked about earlier, where they found 1 in 10 people have this and it's undiagnosed, what they did in that study was somebody just set up in a doctor's waiting room. They set up a table, and any patient who walked in the door that day, they just did positional testing on. So they weren't necessarily there for dizziness. They were there for their yearly checkup or for whatever reason. And the person that was running the study found that 1 in 10 people that walked through the door had BPPV. And this was also replicated through additional studies that found similar results. So this is something that can be present, maybe not as symptomatic in some people, but could be affecting their daily lives without really knowing it. So getting tested and getting checked out, especially if you're finding issues with balance or brain fog, or you feel a little off, or this is something that kind of comes up yearly, getting that checked out by somebody who has a background in this could be very, very helpful and enlightening. And I was going to say, I'm looking at the comments, and I'm finding that people are talking about having other conditions along with this. And I think that's something that we should probably touch on, is that BPPV can mimic other conditions, right? Or you can have BPPV in tandem with other types of vestibular dysfunction. So this will kind of go hand in hand with anybody that's had an inner ear dysfunction, an inner ear issue in the past. Anything that you've had happen that might have damaged that inner ear organ makes you more likely to develop BPPV down the road. The same can be true for people who suffer from migraines or Meniere's disease or have had a history of vestibular neuritis. Even people with vestibular dysfunction are more likely to have hearing loss associated with this and tinnitus. So it is to say that it's very rare that BPPV happens just in a vacuum with itself. And a lot of times it's more common to see this as a secondary condition to other vestibular inner ear issues.
That's amazing. So that's interesting, because I think when you have people thinking that, well, the Epley maneuver or particle repositioning didn't work for me, so I'm still symptomatic. We're looking for a one and done sort of diagnosis, but sometimes people have more than one thing going on. So at least for me, I know if there's BPPV present, I'll treat that first and then see what remains. And sometimes what remains could be something else related to the vestibular system, or sinus issues that are chronic that make a person feel a certain way, or head or neck issues or musculoskeletal things that contribute to how they feel. So, you know, I think most therapists talk about peeling an onion. You know, we're going to try to take away the biggest thing first. And that includes both sides. BPPV can be one-sided or both sides, right? And what
Oh,
happens
yeah.
with that? How
Yeah.
common is that, and how do you know where to start?
So what's interesting is it's definitely a little bit less likely to have bilateral or both side involvement and also multiple canal involvement. You'll see this in cases with people that have maybe whiplash injury, head trauma, something that might have caused significant injury to the head to knock those crystals loose. But it's not uncommon to have it in both sides. Occasionally, when I do see this, we'll treat one side or one canal one day and have them rest for a day and come back to continue with treatment. It might take a couple more treatments because it is going to be a little bit more stubborn. If that's the case, it's just kind of peeling apart what's the worst side, which side feels worse first.
Right.
Let's fix that, and then let's move on to the next. I try not to exacerbate my patients too much in one visit so that they will come back. So spacing them out and going with patient comfort is fine. I've also had some patients that are just saying, let's just get this all done today, and they'll take their time to go through cannula repositioning maneuvers with me. But you can have it in both ears. You can have it in more than one canal. And it's just going to take the clinical decision making of the vestibular therapist to really pick that apart and know what they're looking at and feel confident in what they're treating. And sometimes it's let's try this maneuver and see how you present the next time you come in. Keep in mind with this condition too, you can present differently from visit to visit. We might move those crystals back to where they belong with a repositioning maneuver, and something might knock them out of place again in a different canal. So when you come back for retesting, we might find something a little different. Doesn't mean that it was misdiagnosed or treated wrong the last time you were in. It just means that things shifted around. We reevaluated how you felt that or are looking and feeling that day, and we're treating accordingly to what we see. So that's the one thing I love about watching these eye movements during testing is that you can't fake it. It happens only if this issue is there, and it's not something where I'm like, maybe this isn't the problem. If it's there, it's there. We'll see it, we'll diagnose it, we'll treat it. And there are lots of different ways. I see some people who are mentioning the OmniMax Epley chair, and that's this big, it looks like a big gyroscope of a machine that you sit in, and the computer measures your eye movement, diagnoses where those crystals are, and will slowly turn you to put those crystals back into place, which is essentially the same thing that we're doing with our cannula repositioning maneuvers on a treatment table, just with all the less fancy equipment. Yeah.
Yeah, for me, I used to run a balance center in Houston, and the Texas Medical Center had all the fanciest equipment, the same as NASA had. And really, when it came down to fixing people, it was our hands and our eyes and our experience in watching people. So, I have patients ask me about those 3D repositioning machines, and I wouldn't recommend substituting what our experience and our hands can do. At least in the thousands that I've treated, there are little tweaks, there are little repeats, there are little things that go on that I just wouldn't want a straight algorithm to do. And that's not to judge the machine. I think that it's good, but for me, it's cost prohibitive. I can't have it in my clinic. And I can take my hands and my chair to anyone's home and even evaluate and treat them in their own home at the foot of the bed. So technology, comes out sometimes, and it's interesting and it's neat, and it emerges from study and a deep interest and inquiry into the science of these things. But, for me, at least, I've just sort of simplified it down to the healing art of looking, listening, touching, and repositioning, and then even thinking about other exercises. So is that an approach you share? Yeah,
I feel the same exact way. I mean, there are some times where we run into differences or discrepancies in patients where maybe their anatomy is a little bit different. So we have to tweak the maneuver based on how they're presenting, what their anatomy might look like. We try different types of approaches and different things that pop up that we don't think about. Like, usually when we think textbook BPPV, we imagine these little particles floating and we can put them back where they belong because they just move the way they're supposed to. Sometimes they don't move the way they're supposed to. Sometimes they form a big bolus or a big clog, and they can bottleneck in the ear. And sometimes we have to vibrate those loose, or sometimes they're stuck to the little sensor that is at the very end of that semicircular canal. And we have to be a little bit different in approaching our treatment options.
Right.
Being able to see this and how the patient reacts, and then to be able to quickly go into some reactionary measure is actually very important to me. I feel more comfortable when I can have my hands on the patient, reassure them, and look at what I'm seeing and feel confident in what I'm seeing instead of hooking them up to a machine. But again, like you said, technology is changing. It's fun. It's exciting because it's allowing us to do different things. But when it comes down to the nitty gritty basics of it, all you need are 2 hands and 2 eyes to work with a patient to get them through an evaluation and treatment, which is phenomenal when it comes down to being able to see patients in their homes and bring the access to the care to them. And I had somebody had mentioned in here, asked about if Medicare covers something like this. And I will say absolutely. Medicare is very interested in preventing falls and the hospitalizations and surgeries and rehab that comes with a fall. A lot of times Medicare covers the initial evaluation for a physical therapy appointment, and going into your evaluation is the first step to diagnose and figure out what's going on and potentially getting treatment. So going into that first treatment session covered by Medicare is actually a great thing to be able to get your diagnosis and your treatment a little bit faster than putting it off and waiting down the road. So this is something that Medicare and other insurances really do cover and they reimburse for.
That's a good point. You know, physical therapists and others who participate in vestibular rehabilitation, some OTs and maybe some audiologists, physician's assistants, I guess. I'm not sure all the different people getting into the ring now, but they have time, sometimes more time than the doctor does to examine. And we might have touched on this already, but sometimes the test is negative in the office and then it's positive when you get to the therapist. Do you find that sometimes you can spend more time teasing it out? And if someone had direct access to physical therapy in your state, do you recommend that? And how do you assure them that you'll refer them on if they need help?
That's a really good question. So yeah, the practice acts are going to differ from state to state, and whether or not you have direct access or not. You know,
what does that mean? Tell them what that means.
So that would mean going directly to your doctor without a referral. So in most of the states that I've practiced, they have some form of direct access where if they had dizzy, they Googled what was going on and they found us through vestibular.org or something along those lines. They can call us and get an appointment without a doctor's prescription. With that being said, you know, we still keep their doctor in the loop. We do a whole evaluation that looks at what's going on with the patient, and we send that evaluation off to the doctor to sign off on. So it essentially becomes a prescription or a referral. But also, it's important to note that there's been a shift in the physical therapy world as far as education-wise. So it is now required for every physical therapist that comes out in the working world to have a doctorate. And one of the reasons for that was to have the ability to differentiate, to recognize red flags in patients. So it is our duty, especially as direct access therapists, to make sure that we are going through all of the boxes and checking off all the things and looking for the red flags to make sure that they don't need to see somebody else first before they see us. And there have been times where I've seen somebody come in off the street with these symptoms. I do my evaluation. I recognize as something that this is not something that's appropriate for me to treat, and they need to get to the right person. But the one thing that's great about physical therapy, and again, I'm a little biased being a physical therapist, but we have the time to spend with our patients. Whereas it's very difficult for MDs and doctors and PAs and these people to spend more than a couple of minutes because of the quantity of patients that they have to see. With us, we designate typically 45 minutes to an hour to sit down with the patient and listen. And also with physical therapy, we tend to see them followed up. So we might see them once or twice a week for the same amount of time and really get to dive into what's going on. We look at the picture holistically. So when I do an evaluation for a dizzy patient, I'm not just looking at the eyes and their ears and asking them about their dizziness. I'm watching them walk. I'm watching them balance. I'm watching them move and coordinate their movements. I'm looking at the strength in their legs. I'm doing neurological tests to make sure that the brain is functioning the way that it's supposed to function. And it's not until I get to the end of that evaluation and I look at all of my testing that I make the recommendation, yes, physical therapy is a good option for you, or no, I want you to go see a neurologist first, or I want want you to go see an ear, nose, and throat doctor. Or you need to go back to your doctor because I'm finding X, Y, and Z. And it's interesting what that pops up with that. But it's been really cool to know that we can be that kind of a gate person for patients who are trying to navigate where they need to go. I have patients that come in that they might have BPPV, but they've been experiencing these symptoms that sound like vestibular migraine. Okay, we can treat the BPPV, but now because of these other things that I found, I want you to go see Dr. So-and-so because I think that he's going to be able to help you with these additional issues that have been going on that we found pop up today. So we have the education in the background for this. We take our time with our patients, and because of our practice, it's allotted us all this time to work with these patients, and we're not scared to refer. We have to refer. We don't want to treat something that we can't treat. We want to make sure our patients are happy and healthy and well taken care of. So that's definitely something that we focus on in that first evaluation.
I always say pick a practitioner who knows what they know and knows what they don't know. And so, you know, I think that you're right. We are interested in people finding wellness and ability to move about and live their life. And so if we can't help you, we certainly want to refer you back. Sometimes we help you and we refer you. And sometimes, you know, we refer you first to get something checked out and then come back. Because testing can be helpful in the vestibular realm. But in the case of benign positional vertigo, again, the clinical guidelines do not recommend even an MRI before trying particle repositioning by a licensed therapist who specializes in vestibular rehab. Same is true with an audiogram. Hearing tests are not part of the clinical guideline if the person has benign positional vertigo. Again, that is a diagnosis that can be made easily with certain positioning and observing the eye movements, listening to the patient who has symptoms in those positions, and then directly sending them for treatment. So it sounds like there's some people on here that have tried it and it hasn't worked. I know what kind of practice I have, and I know you have a big practice too. What do you say to people who reach out to you and say, you know what, I've tried vestibular therapy and I've done the Epley maneuver and I've done particle repositioning and I've done somersaults and I've done all these things and nothing helps? What do we say to those people? And I say we because I think we all as one want to have a magic answer. But what's your advice? That's
hard. The way I usually approach this situation is I want to see the patient for myself. Just like with anything, you know, people are going to vary in their experience and their background and their different techniques and approach to therapy. And I typically encourage patients who are still suffering from symptoms or they're fearful even because they become so nauseated and maybe produce a lot of emesis during treatment to just come in and talk.
What's emesis? What does
vomit?
That mean?
Vomit. The glorious side of this job.
Nausea and vomiting. They have that. Yeah.
You know,
so
there
they
are
can't
some people that can't tolerate it, or they had a terrible experience with another clinician that was like, you'll be fine. Let's just drop you back and try it. I usually recommend those people to come in and just sit and talk. We don't have to do necessarily anything that is symptom provoking that day, but to come in and get a better understanding of what's going on to see if we can help guide evaluation better. There are different techniques and tricks that I do with patients to get them through an evaluation with as minimal symptoms as possible. And I also educate them on how to do some research into the clinician that they might see and get a second opinion or take a second chance with.
What would you ask a clinician? To decide if they're what you need.
Yeah. So, I mean, going through the directory, I usually say is step number one. And the reason why I say this is because the people who are on the directory are members of VITA. They have found value in investing in this amazing organization to put their information on this directory because they have background knowledge of how to treat these conditions. So that is your first filter, number one. And then what you want to do is go through and call people in your area and ask them about their experience. What kind of conditions do you treat? Do you have technology for testing? How often do you see this? Where have you gotten your training? You want to kind of ask these questions and don't feel bad like you're questioning their background or you're questioning their ability to practice. I found the most honest answer is that people will tell you if they're not super comfortable, if it's not something they treat on a daily basis. And if they are comfortable, they'll be the first one to jump on the phone and say, listen, I know what I'm doing. come on in. I want to see this, that, and the other thing. We treat this, and they'll be happy to tell you about their background. So doing your research is kind of the first place to start, and just kind of pick apart and kind of take your time to go through and interview these clinicians. So, you know, how long have you been doing this? How often do you see this? What conditions do you treat? You know, typically, how many visits have you seen these patients? Sometimes can be a little bit of an indicator to you whether or not they've seen this a lot or a little. So you want to kind of have your list of questions, and then you can also share your symptoms with them and say, I'd like to talk to the therapist a little bit about my background to see if they think I'm appropriate for their practice. So go on and see if you can talk to them.
Yeah, because there are some cases, would you say there's some cases that are atypical or unusual that need a little more tweaking? And in that case, you would ask the person to ask the clinician, you know, how many years have you been doing this, or how many patients have you seen, or are you comfortable with atypical?
Yeah,
BPPV?
absolutely.
Yeah.
Especially with BPPV, I'll have someone call and say, listen, I've been through the ringer with this. I have seen so many people. Nobody's gotten me help. What are you going to do that's different? And a lot of times the honest answer is, I don't know if I'm going to do anything different because I don't know what you've gone through and who you've seen. But here is how I approach my care and my treatment with patients that present to you. And I will do my very best to make sure that we can get you some help. And if this isn't something I can help you with, then I'll point you in the right direction to somebody who can. So, you know, I actually had a patient who I'm seeing next week who called another therapy office in the area and said, listen, I called them and they told me to call you. So, you know, it's something where somebody will be very honest with you if they don't want to treat or can't treat your condition, especially when it comes to being atypical. If you have a hard time tolerating treatments or you've had no success in the past, call ahead and see if you can talk to the therapist or talk to the office staff and get a feel for what they can do.
Do you think people can get 100% better?
They can. With BPPV, yes, I think they can. But I like to manage expectations. Sometimes if they have BPPV because of some other inner ear dysfunction, the answer is they most likely won't get to 100%. It's going to vary on a case-by-case basis, and I don't like to sugarcoat it because sometimes it's about finding the new normal, finding the quality of life, and getting back what you can and enjoying life. But when it comes to BPPV, a lot of times, yes, you can get back to functioning completely 100% normal, but there is a small chance there that whatever might be lingering in the background can also diminish that return and get you to maybe 90% or 95%. So it's going to vary from person to person, but there is hope. There always is hope. There's always something that we can do, that we can work with that at least help reduce symptoms and make you feel better.
When you finish with a patient, are there ways that you can tell them that maybe they can avoid recurrence?
Mm-hmm. Yeah. So I like to think of BPPV as something that kind of slowly builds up over time, almost like sand in an hourglass. If we stay in a prolonged position, like lying on one side or lying flat in our bed, those little crystals can slowly slough off over time and fall into those canals. And it's not until one morning when you've built up enough crystals that you sit up and you get dizzy. So one way I suggest patients avoid recurrences is by either sleeping with the head of their bed a little elevated or maybe with a wedge. By just changing your anatomy in relationship to gravity, that can prevent those crystals from slowly dropping into the canals over time.
What does that mean, change your anatomy?
So
relationship to gravity?
Your canals and your inner ear is positioned in your head in a very specific way. And when you're lying flat on your back or lying on your side, the openings to those canals fall directly underneath those little organs that have the crystals on them. So if we can elevate your head a little bit, you change where that little opening is in comparison to those little crystals and where gravity is so that they're not slowly dipping in there over time. So I've had a couple of different recommendations I've given patients. You can either put little risers, like 2 or 3 inch blocks just under the feet of the bed on the end where your head is laying. I've had some patients get those automatic adjustable beds where you can just raise the head up a little bit. I recommend sleeping on a wedge, something that has a nice gradual slope so your neck isn't, cricked all night on 2 or 3 pillows. But those are some of the ways that you can prevent recurrences. Also, and I see this popping up, it's a little bit of a buzzword in our chat, the dentist's office. Make your dentist aware that you have BPPV. If you think about it, when you are getting some dental work done, your head is turned and you're laying back in such a position that if they vibrate that skull with a dental drill, there's a chance they can shake those little crystals loose and they fall back into the canals. So see if they can readjust and work with you in a way where you don't have to lay back so far to kind of help prevent that. Same thing at your hairdresser. If you don't want to lay back all the way in the bowl, a lot of places have these little trays that they can wash your hair by putting a tray on your neck so you don't have to lean back so far.
I'm scared of the dentist, and I don't have BPPV. Yeah, that's true. And so, and if you can't avoid those positions and you go to the dentist and you have it again, you know, do you just advise call the therapist back right away? Don't wait and hope that it goes away, but get right back in. I tell people, get right back in and get it fixed again. Because
specifically schedule appointments. So if I'll ask my patient actually if they have a hair appointment or a dental appointment coming up anytime soon. And if they go, I do, why? I'll schedule an appointment for them same day for them to come in for me to do a quick check on them and to just evaluate positioning and do maneuvers if need be.
The other thing I think that does kind of correlate with people getting it again is some people, and it makes people think, oh, did this cause it? Like they'll say, does the dentist cause BPPV or does the hairdresser cause it? No, it just kind of makes it possible for those particles to shift again. They ask me that about airplanes. And what do you think? Does airplane pressure in the cabin cause BPPV?
No, I would say directly no to that. However, I will say that I can see where patients maybe make the correlation between flying and having recurrences. One of the most popular times that I see this happen is right after the Christmas holidays. For the last 2 months, patients have been traveling, exposed to new germs, off their diet, a little bit stressed. Their sleep patterns are thrown off, maybe more stressed at work and holiday shopping. And all of these factors, the stress, the change in diet, the change in sleeping, sleeping positions, immunity response because of being exposed to new germs creates a reaction that makes it more likely for them to have a flare-up or a recurrence. And then you add airplane travel into that because they're visiting family, and voila, people associate the vertigo or BPPV coming on with flying in an airplane. And this is just in relationship to BPPV. I will say that there are different types of vestibular dysfunction that may be triggered by changes in pressure, where flying can bring on a vertigo attack or cause symptoms of flare up. But we are just strictly speaking in terms of BPPV. And it is my belief and my clinical judgment that flying in an airplane won't cause BPPV unless you're sleeping in some sort of a position that's going to elicit those little crystals to move into the canal.
It's that terrible head position in the airplane. And I think it happens to people after surgery. Sometimes their head position, they get intubated and their head is tilted back when they put the, you know, if you have general anesthesia, and sometimes laying flat for an MRI, people will get it, but it's not the magnets that do it. It's, you know, the positioning. So this is really a positional problem with a positioning fix for the most part. And there are a lot more comments in the chat, and I think this is a great conversation. Would it be okay if we continue talking about the comments in the on the Facebook page and go back, and would you visit that, and Dr. Tate, and answer some questions for people there? I'm sensitive to the time. We've been on an hour, and so how can people reach you if they'd like to reach you? I'm going to make a banner about how they reach you.
Personally, if you want to reach me, you can reach me on my website. I have a contact form there at www.vestibular.today. On that website, I have some resources and stuff that we talked about today, and I'll be happy to go back into the Facebook chat and reply to some of these questions. One thing I do want to say is that we talked about sleeping with the head elevated. I don't want people to avoid changing positions. So we want to avoid prolonged positioning, like sleeping at night, to let those crystals, you know, not fall into our canals. However, I really want to encourage movement. Typically after canalith repositioning maneuvers, I tell my patients, move. You've got to move. You've got to keep active. You have to keep moving your head. Don't be afraid to bend down. What happens is we start to adjust to these automatic compensatory changes, right? When we feel dizzy, we then avoid the things that make us feel dizzy. So my BPPV patients might come in and they'll kind of start turning like this instead of moving their head to look around. They avoid lying down flat, or somebody had mentioned having to look under the couch. They avoid bending down really far. Don't avoid it. Get back into your normal movement so that your vestibular system adjusts to the movement. If you avoid movements for too long, that movement starts to feel foreign to your body and makes you feel like you might get dizzy. So some takeaways from today. It's always best to get diagnosed by a trained clinician that has a background in vestibular therapy, number one. There are lots of different ways that you can go about treatment, including going on our provider directory, finding somebody near you who can help. You can look for self-treatment options. You can do the hope and wait. There are different approaches to whatever you're comfortable with. If you do seek help, don't be afraid to poke and prod at that therapist a little bit before you go in. Make sure you feel comfortable with them and that they feel comfortable with your case. And there's always hope. There is always hope for this, and that this is something that will get better, and it's something that is very treatable, and it shouldn't be something you should be afraid of getting treatment for. There are so many more benefits to resolving BPPV and the symptoms than it is to just let it continue to affect your quality of life. I highly recommend that you guys go to vestibular.org and look more into VITA and the resources there. It wasn't until I became a member and started volunteering that I realized how vast VITA is, how much I use VITA on a daily basis, and how great their articles are for education, not only for the patient, but the clinician. And also, this week is Steps to Balance, which is a spring summer campaign that we run to help raise awareness and help people feel supported in their journey back to balance. You don't have to be a patient. You could be a family member. You could be a friend, a loved one, just to understand what they're going through and to help them through the tough times that they'll face trying to get back to having a balanced life. Steps to Balance is a way that we celebrate that. So keep an eye out for Fiona Flamingo Bingo and all the fun things that you can do to help motivate and get people moving, and donate. The organization is a nonprofit and relies on donations to help continue developing these resources and do more amazing things for our vestibular community. So I highly recommend you guys check it out. Utilize the resources from everything in patient advocacy to patient support and education, and let them know what you guys are doing with your journey back to balance.